hunger. We will only realize this vision together. Together, we will come back stronger. Together, for a future with health for all, hunger for none.
My journey continues, and I know I'm not alone. Because together, we can make a difference every day.
Okay, good morning and welcome to the 14th Congress of Asci in Vietnam. And this is Asci Meets SCCT session, and we will learn about CT functional assessment of coronary artery disease. And this session is moderated with my co-chair, Professor Cohen Neiman in Stanford University. Professor Neiman, please.
Good morning for you. Good evening for me. It's a pleasure to be here. Obviously, I would have preferred to be there live, as for all of us, I think. But it's great to have this session. We have a long-standing collaboration between ASCI and SCT on a societal, but also on a personal level. So it's great to have this session. We'll have 4 great talks. After these talks, we'll have some time for Q&A and discussion. So I recommend please leave your questions in the Q&A in the chat box, and then we collect those and use that for the discussion. So without further ado, I suggest that we get started. And the first presentation will be by Sania Bara, who I've known for a very long time, also during 1 year that I spent at MGH when he was still there. He's currently in Texas at the University of Texas Southwestern Medical Center. He is the division chief of cardiothoracic imaging at UT Southwestern and the chief of cardiothoracic imaging at Parkland Health and Hospital System. Sunny has published an enormous number of papers. He's a true educator, and I think we all learn a lot from him from his presentations and his chapters. And I should not forget, he's also a former president of SCT. So let's give the floor to Sunny.
Hello, my name is Dr. Sonia Bara, and I'm honored to be joining ASCI 2021. I'm joining from Dallas, Texas. Unfortunately, I was not able to be there in person, but I'm hoping to be at a future ASCI meeting with you. I will share my screen. My topic today is spectral detector CT in cardiovascular applications as contrasted to conventional CT. These are my disclosures. And the objectives are to review the technical aspects of spectral detector CT and to illustrate potential future applications. So first, about the differences of source-based spectral CT and detector-based spectral CT. Source-based would be the rapid KV switching or the dual source or the split beam, where you have 2 separate spectra of X-ray beams emitted with a peak kilovoltage of 140 and 80, for example. So those 2 different spectra go either through the patient at different times or at different angles, and you have a single set of detectors listening on the other side. Detector-based, on the other hand, spectral CT, that would be the spectral detector CT or the sandwich detector or photon counting. It has a single spectrum peaking at 120 or so kilovolt go through the patient. So 1 spectrum only going through the patient. But then you have either 2 separate detectors or maybe 4 bins with photon counting, looking at photos of varying energies on the detector side. So the easiest way to do spectral CT is to scan the patient twice. Of course, there's a lot of time and potentially motion between the 2 scans. And that is, of course, a disadvantage in that there will be misregistration and motion artifact. GE has a rapid KV switching where every few milliseconds the KV gets switched from, say, 80 to 140 or 80, 120. So they're not in identical spatial locations, but very similar, and the switching happens very rapidly. One issue is that you can't use all of your dose-saving techniques, and you have to premeditate that you want to use dual energy. If you didn't do it, you will not have the data. This is the Siemens version where you have 2 X-ray tubes offset by 90 degrees that rotate around the patient like so. So you have simultaneous acquisition. But both of these acquisitions would be offset spatially by about 90 degrees or so. You also have to prospectively turn on that mode. If you didn't turn it on, you will not have that data. Here's another way of getting this also, Siemens, by having one X-ray beam spectrum emitted from the scanners. Let me just show you the credit here. Stefan Ulsheimer produced those two. And then you have filters that create a lower energy and a higher energy spectrum from that one spectrum that comes out of the X-ray tube. So that filter is right after the tube. The patient would be in here. And you have basically split the beam. That's why this is called split beam or twin beam dual energy. That's done with a single source system. And lastly, there is the spectral detector CT, and I will focus mostly on that technology for the rest of the talk, where you have a regular X-ray tube, but you have two detectors like a sandwich on the opposite side, and it rotates through you like normal. And the idea is that the lower energy within the spectrum that goes through the patient is seen by the first detector, and the higher energy is seen by the second detector. In reality, this is how it looks. This is the spectrum that is identified by each of these detectors. So there's some overlap here, but there is incremental information in the some of the areas above those initial curves. And here is the reconstruction chain using source-based on the top and spectral detector on the bottom. The main difference is that you will reconstruct a high and a low energy DICOM image set. And then in the DICOM images, you would use that information to create all your derived views, the water, no iodine, or virtual non-contrast, or any of the others. Contrast that to the photoelectric and Compton reconstruction being bundled into something that the vendor calls spectral base image with this, the Philips approach, a spectral detector CT. This is not an image that you can see, but it has the information, and you use the spectral base image data set to create the same reconstructions derived from your images. This is some work that was presented by one of the researchers in our group, Dr. Todd Susby, that received the Hounsfield Award at the Asci BTMR, that basically illustrates how with conventional CT you use a one-dimensional scale or array that has various Hounsfield units. So air is minus 1,000, water is 0, and so forth. Calcium would be above 200 or thousands. And what spectral detector CT does, or spectral CT in general, it takes this and it plots it in 2 dimensions, the Compton scatter versus the photoelectric effect. And some of these attenuations that look the same in a conventional CT will look different on this plot. So for example, water and air would not look different. However, fat, bone and iodine look the same, but you can separate them out using either the Compton and photoelectric or the high and the low KVP images. So you're basically adding a dimension. And if you plot all the voxels that you have scanned, in this case it's a billion, multiple billion voxels, into this photoelectric versus Compton data set, you'll be surprised because there's only very few well-defined spaces where you can see things. So if you zoom in some of the voxels here, you'll get this. See this one dot here? This was only present in 4 out of the first 100 and some patients we scanned. And Matthew Lewis looked at that spot in these 4 patients, and we created a software that allowed region of interest creation on that plot. That's basically this area, and back projecting only those voxels back on the image. And in this case, they selectively identified silicone in these patients that had breast implants. So using this material attenuation decomposition plot, you can also circle other areas. For example, this one that most patients had. If you project that back, you selectively get cartilage, see costochondral cartilage and in the disc spaces here. So now you have a tool that allows for some degree of tissue characterization that conventional CT does not allow for. You can use that to identify isoattenuating gallstones. Yeah, I know that's not in the heart, but gallstones can be isoattenuating, where the gallstones are not visible because they have the same attenuation as bile. But some of them are cholesterol gallstones, and they would separate out in this two-dimensional space using spectral CT. And here's a study that we did. So all of these contain gallstones. Some are visible and others are not. So we looked at a study where we manually drew the stones and we projected them in a different color back. So you go from invisible, conventional, to visible. And we asked readers, we had 5 readers look at those, looking at conventionals, at virtual non-contrast, at 200 keV, 40 keV images, and using this material attenuation decomposition plot to identify gallstones. And this is your ROC curve, the area under the ROC curve. Conventional is exactly like guessing. VNC is a little bit better. 240 keV are much better areas under the curve. You can see this is like 0.8. That's pretty good. But if you go to the segmented, the area under the curve is nearly perfect. So using this method with the MAT plots and the segmentation of cholesterol versus bile led to near 100% accuracy in this study. And it works in vivo as well. This is a scan that's done in vivo, and you can see it is very easy to identify these gallstones now. And this is how it looks with 40 keV and 200 keV. You can tell a little bit better, but it's really hard still to see the stones in some of those. All right, let's look at iodine quantification. You are able to quantify iodine, as shown in this example of an infarct, and it gives you a number using spectral detector CT. And we wanted to get to the bottom of it, so we created a phantom with water, some contrast, a large amount of contrast in the background, and with vials that had certain defined levels of concentration. And we plotted that, and we found that this actually works reasonably well. This is a very good correlation between the actual iodine concentration and the measure that we got. So that was very encouraging to us. With very small vials, there was still some beam hardening or pseudo enhancement that didn't completely disappear with this method. But we were reassured that the number that the scanner will give you is actually meaningful. So if you now can quantify the iodine, you can use that information together with the hematocrit to create and calculate your extracellular volume as shown in this study that was published in Radiology Cardiothoracic Imaging. Here's the MRI as the reference standard. Here's the CT. There was only a minimal bias between the two that showed really excellent correlation. The R2 is 0.94. And note, spectral detector CT has a much higher spatial resolution, so hence the image looking nicer or more detailed than the MRI image. That's the reference standard. So this was used by another group shown here to show a case of an infarct using iodine density to bring out the scar a little bit better, to look at the extracellular volume, and here is the lesion that corresponds to that area in the diagonal branch. This is the MRI as the gold standard or reference standard, which is really beautiful correlation. So congratulations to the authors. Virtual monoenergetic images can be used to reduce artifacts from metal, as shown here. So the black streak artifact can be substantially reduced at higher KeV, but it also gives you more image noise. So this study from Leonard Penning and others looked at identifying the best combination of virtual monoenergetic images. That you can see the conventional image had too high Hounsfield units when you had these hyperdense artifacts. See, that should be down here where it's 0. And that gets corrected at 200 keV, but look at the error bar, there's a lot of noise. Now, if you combine the virtual monoenergetic image with the MAR, the metal artifact reduction, you can see that you have much lower noise, lower even than on the conventional images, while you have complete correction of the attenuation value. So they give us optimal values for the generators of 140 to 200 keV plus MAR, and for the leads at 100 keV plus MAR. Iodine boosting can, of course, be done with low monoenergetic images. Looking at this, you have 100 keV images showing the RV looking not very opacified, but the same scan at low mono E shows the iodine having much more signal in the same image. So you can boost your iodine. And this is a study from Japan that was given to me, shared by Philips. Thank you to the authors. That used a very low amount of contrast to do coronary CT. And naturally, the images don't look very nice at conventional 120 kVp. But look at that, at 50 keV monoenergetic images, the coronary arteries are absolutely beautifully opacified. And that's the amount of contrast they use, something like 7 cc's that fits in a little 2 bottle caps. Here's the curved multiplanar reformation showing that these images were actually diagnostic quality. So wonderful work there. And then this is a study that looked at coronary CTA trying to minimize radiation dose by either using low KVP, which is what we used to do, conventional images, or standard KVP, but using spectral detector information and low monoenergetic images. So they randomized patients and they scanned them at about the same radiation dose. And here's some of the results. Let me help you read this. All of this is the spectral detector acquisition with the 120 kVp conventional. And here is the 100 kVp conventional. You can see that the conventional acquisitions between the two, they look very similar, but the contrast to noise ratio is much higher with the low monoenergetic images in the aorta and all the coronary arteries. So this study showed that you can improve or boost the image contrast. And here's that 100 kVp image and the low monoenergetic image at 40 keV. So excellent image contrast to noise ratio compared to 100 kiloelectron volt, kVp at about a similar very low radiation dose. This is an interesting study looking at iodine concentration to determine whether a chronic total occlusion can be revascularized. In this study, the authors have done 50 cases of chronic total occlusions, 16 of which were unsuccessful, they failed. And they looked at a few millimeters after the chronic total occlusion, they measured the iodine concentration in that area. And they found that the coronary iodine concentration at the entry of the CTO, 1 millimeter down from the beginning, in failed PCI and failed revascularization was 1.3 milligrams per milliliter. And in those that were successful, it was much higher, 5.2 milligram per milliliter. That was statistically significant. And they found a cutoff point of 2.5 milligram per milliliter to predict the failed PCI with pretty high accuracy values. So the negative predictive value would be 93%, sensitivity of 87. And the odds ratio here was 27, so rather substantial study. This article in Radiology Cardiothoracic Imaging had a wonderfully written editorial by Drs. Rubinstein and Blankstein, who reminded us of all the other criteria that CT gives us in addition to the spectral information that we get. Namely the amount of coronary calcifications, the length of the chronic total occlusion, the blunt versus tapered cap, and now the iodine concentration, that's a new one, but whether the vessel is tortuous, and if you have a good distal vessel beyond the CTO as a landing site, among others. So with that, I'm all done with my presentation. Again, it's been an honor to participate, and I thank you very much. And I'm hoping to see all of you in the future in person at an Asci meeting. Thank you.
Okay, thank you very much, Professor Barra. It was a really wonderful lecture and great images. So let me introduce the second speaker. Second speaker is Professor Hyun-Bok Park from Korea. He's currently assistant professor at the Division of Cardiology, International St. Mary's Hospital, Catholic Kwangdong University College of Medicine. And he's actually an expert in the relationship between the CT atherosclerotic plaque characteristics and FFR, invasive or CT. So this is going to be a very nice talk. And his talk is CTFFR with a subheading of opportunities and challenges. So Dr. Park, please.
Hello everyone, my name is Hyun-Bok Park from International St. Mary's Hospital in South Korea. The title of my talk is CTFFR, Its Opportunities and Challenges. I have no disclosure. Firstly, I will review recent trials of CT-derived FFR, and then we'll discuss about challenges of CTFFR. Finally, we'll suggest possible solutions for that. As we know, obstructive CAD, identified by invasive coronary angiogram or coronary CT angiogram, poorly correlates with region-specific ischemia by FFR. Therefore, a lot of false negative and false positive results we could get from it. In COURAGE trial, in BERRY-2D trial, PCI did not show clinical benefit compared to medical therapy group. Therefore, decisions of coronary revascularization should not be based upon anatomical stenosis alone. However, in FAME-1 and FAME-2 trials clearly demonstrated the benefit of FFR-guided PCI, showing that 30% reduction of MACE in FAME-1, 70% reduction of MACE in FAME-2. Then can CT also diagnose ischemia? As you can see, this mild stenosis region and this severe stenosis region in CTA, which one do you think is ischemic? Interestingly, this mild stenosis region showed ischemia. This severe stenosis did not show ischemia. Therefore, we need CT-derived FFR by non-invasive methods. The first off-site CT-FFR technology was developed by Hartford company called FFR-CT. They got patient-specific arterial geometry from coronary CTA and then generated 3D lumen segmentation model through subvoxel resolution evaluation. And then 3D mesh generated, boundary conditions were calculated, and using computation fluid dynamics, finally they provide this beautifully illustrated FFR-CT report. However, this technology has several limitations. First, CT images must send to Hartford. To do this huge amount of calculation, they need to use supercomputer. Also, significant time and cost occurs. 3 prospective clinical trials were performed in 2011, 2012, lastly 2014. First clinical trial, they've got fairly good accuracy as 87% per patient basis, 84% per vessel basis. However, their first multicenter trial, they've got relatively lower accuracy as 73%. And after that, they performed another multicenter trial. They got excellent accuracy as 81% per patient level, 86% per vessel level. With this data, they got FDA cleared. In their recent NXT trial, they showed FFRCT correctly reclassified almost 70% of CT false positive to true negatives. In platform study, FFRCT showed its clinical benefit by reducing 61% of pre-planned invasive coronary angiogram and 83% reduction in non-obstructive stenosis detection rate in invasive angiogram. And FFRCT also demonstrated its good prognosis in short term at 90 days and in long term almost 5 years prognosis. Very recently, FFRCT was compared to CTA, SPECT, and PET scan at the same time. FFRCT showed highest AUC value as 0.94, PET scan 0.87, CTA 8.83, SPECT 0.70. FFRCT also showed highest diagnostic accuracy per vessel level as 87%, but per patient level, PET scan showed the highest diagnostic accuracy as 88%. Next, CT-FFR technology developed by Siemens company called CFFR. This is an on-site CT-FFR technology. Instead of using full order model, which needs to use supercomputer because of multi-scale coupling and large-scale computation. Later, they used reduced order model, kind of simplified model, and they significantly reduced computation time to 5-10 minutes per case. So they performed clinical trial in 2014 and 2015. However, CFFR accuracy showed relatively lower than FFRCT as 75%, 78%. So they developed second generation CFFR machine learning technology. This method based on deep learning algorithm that further reduced computation time to 1 to 4 minutes per case. In this technology, they used multi-layer neural network architecture to train already CFD simulated models, more than 12,000 cases, to learn the complex relationship between the anatomy of the coronary tree and its corresponding hemodynamics. Therefore, whenever a new case comes in this algorithm, instead of calculating CFT simulation, this algorithm just provide machine learning based CT-FFR values. So they tested this technology in 351 patients, 525 vessels. They've got 78% of accuracy. Another type of CT-FFR is structural fluid analysis based Toshiba CT-FFR. Prior CT-FFR technologies, such as FFRCT and CFFR, used boundary condition determined by kind of assumptions regarding microvascular resistance. However, they directly calculated boundary conditions from the structural deformation of coronary lumen and aorta. Therefore, they need more than one phase of a CT scan. So they need 4 diastolic phases, CT scans, to assess luminal deformation of coronaries and aorta. So this structural deformation information translated to boundary condition, and boundary condition applied to fluid simulation. So this technology also used reduced order model, on-site CT-FFR, performed in relatively small number of cases, 56 vessels. However, they've got fairly good accuracy as 84%. Another type of CT-FFR is TAG-based UCT-FFR, developed by United Imaging Healthcare. So this group also calculated boundary conditions from TAG, transluminal attenuation gradient. So this calculated boundary condition coupled to CFD simulation. In their CFD simulation, they simply used open source CFD package. However, they've got fairly good diagnosis accuracy as 91% in 338 patients, 422 vessels. However, 14% of patients should be excluded because of failed calculation. Finally, our group also developed on-site CT-FFR technology called parallel computation-based VFFR. To do on-site CT-FFR, we did not use reduced order model. Instead, we used full order model by dividing coronary trees into 40 segments, and each segment assigned to each computing core. Therefore, on desktop level, a cluster with 40 cores used parallel computation method. We could calculate the full order model coronary tree. So calculation time around 10 minutes. We did a clinical trial in 57 patients and 100 vessels. Diagnosis accuracy was 78%, AUC was 0.88. When we adjust FFR cutoff to 0.75, we got much higher accuracy of 87%. Now, let's move on to challenges of CT-FFR. One of the major limitations of CT-FFR is still has significant rates of false positive results, 10 to 20%. These false positive results inevitably lead to unnecessary invasive coronary angiogram. And another limitation is that CT-FFR shows very low diagnostic performances at clinically interested FFR range, such as 0.75 to 0.85. In this important FFR range, the relationship between invasive FFR and CT-FFR were very poor. In FFR-CT, CFFR, second generation CFFR machine learning also. So in this review paper, FFR-CT diagnostic accuracy rapidly dropped to 50% in the range of 0.7 to 0.8. These results also found in machine learning-based CT-FFR, invasive FFR range 0.76 to 0.85, the diagnostic accuracy of CT-FFR around 50%. And another limitation is that CT-FFR shows low diagnostic performances at intermediate diameter stenosis regions. In this FFR-CT de facto data, when they performed intermediate stenosis analysis, diagnostic accuracy further down to 69%. And this CFFR intermediate stenosis analysis showed the same result, low diagnostic accuracy. One of the main reasons of this low diagnostic accuracy is operator dependency of coronary lumen segmentation. To perform CFD computation, 3D coronary lumen segmentation model should be generated. So firstly, semi-automated coronary lumen segmentation software was used, and after that, almost always manual adjustments are required. So in this process, in this study, the same cases performed by 3 different groups: engineer, cardiologist, radiographer. So engineer performed in 6 minutes, cardiologist 15 minutes, radiographer 25 minutes, and also according to operators, diagnostic accuracy were different from 80 to 85%. And the calcium booming artifact can also affect to diagnostic accuracy of CT-FFR. If CAC score more than 400, FFR-CT diagnostic accuracy got lowered. However, CAC score 400 more cases is not uncommon in older population, like more than 70 years old men. Almost 30% showed CAC score more than 400. And CT image quality also can impact on accuracy of CT-FFR. Compared to this excellent CT image, poor image quality scan showed lower diagnostic accuracy. Then what would be possible solutions for this? The relationship between plaque character and ischemia nowadays well established by numerous studies. Plaque volume and burden, high-risk plaque features are well correlated with fractional flow reserve or shear stress. And these comprehensive relationships can affect to plaque progression and plaque rupture. In this study, they use percent aggregate plaque volume defined by summed plaque volume from coronary ostium to distal portion of coronary region to detect ischemia. The AUC value was 0.85. So this percent aggregate plaque volume combined to diameter stenosis or area stenosis, AUC value got much higher, 0.88. Our group also performed this kind of study. We showed the high-risk plaque features significantly correlated with ischemia, especially positive remodeling, rotating plaque. If there are 2 more high-risk plaque features, even in non-obstructive regions, ischemia could be associated. So we nicely showed those responsible relationship between ischemia and high-risk plaque features, and percent aggregate plaque volume. So we got up to AUC value 0.85. In this case example, mild stenosis in invasive coronary angiogram and CTA having positive remodeling, spotty calcification, rotation plaque. This region had showed FFRCT ischemia, and also invasive FFR showed also ischemia. FFRCT de facto data when high-risk plaque feature combined, AUC value went up to 0.87, and in recent NXT FFRCT data combined with high-risk plaque features, AUC value went up to 0.93, and CFFR also combined to CTA, CT perfusion, AUC value went up to 0.94. So very recently, fully automated coronary lumen segmentation and plaque quantification using by artificial intelligence software was developed by Clearly company. In near future, we might use this fully automated lumen segmentation model and plaque quantification information to predict further accurate FFRCT values. In summary, ladies and gentlemen, CT-derived FFR technologies are continuously evolving and proving their clinical utility. However, CT-FFR still has many challenges to overcome for being fully adopted in clinical practice. High-risk plaque features and plaque quantification can enhance the diagnostic performance of CT-FFR, a machine learning-based image segmentation and flow simulation will enhance the complete automation of CT-derived FFR without any operator dependency. Thank you for your attention.
Great. Thank you very much, Dr. Park, for that excellent overview of the field. That was a lot to cover. So I think we'll continue with the next presentation, which is a pleasure to introduce Dr. Teruhito Mochizuki, originally from Ehime, Japan. He's emeritus professor there from the Department of Radiology, and currently he works at the Chechenov First Moscow State Medical University. I would love to hear more about that. But of course, we've known each other for a very long time and very early on used perfusion imaging with cardiac CT and has done great work. Akira Kurata, one of his mentees, stayed with us in Rotterdam and taught us how to do static perfusion imaging. So yeah, it's a great honor to welcome Dr. Mochizuki. I think you want to say a few words first.
Thank you, Graham. It's my very honor to be with you in the session, in this honorable session. I'm very happy with my colleagues. So please start my presentation. We propose the potential use of CT for cardiac imaging in the major journals. We experienced perfusion defect of the acute myocardial infarction on contrast enhancement CT. Excuse me. The images got a cover of circulation. Then we tried to depict ATP-induced myocardial ischemia. This is an early case of ATP-induced ischemia. In the anteroseptal wall, in the ischemic AS wall, there is a hypokinesia. At rest,
no perfusion defect, and normal wall motion. There are two ways of CT perfusion. One is one phase, that is static CTP, and the other is dynamic CTP. This is a case of angina pectoris of triple vessel disease. Before CABG, there is a hyperperfusion in the septal, inferior wall, and lateral wall on one phase static ATP stress CTP. Here. So CABG, liter to LAD, and saphenous vein grafting to LCX were performed. No CABG to RSA was performed. After CABG, hyperperfusion of the septal wall and lateral wall is gone, but the hyperperfusion remains at the non-treated inferior wall. This case shows the potential use of the stress CT to depict ischemia. So we firstly reported the usefulness of CTP comparing SPECT using the 16 detector row CT. This is young Dr. Akira Kurata. He was being interviewed by the press at the ACC. There is hyperperfusion area here and here. The wall motion of the ischemic area on ATP stress it's hyperkinetic here, but at rest the hyperperfusion is gone and the wall motion became normal. This is the diagnostic tree for the stable coronary artery disease. We evaluate pretest likelihood and exercise ECG, then classify the risk of CAG to three classes: low, moderate, and high risk. Low risk patients may be followed up, and high risk patients may directly go to the cath lab. Coronary CTA and CTP are the core of the further examination. Left is a famous figure of Hakamovich in Circulation 2003, and right is a also famous, indicating FFR-guided PCI can navigate better outcome. So assessment of malgal perfusion or ischemia or FFR is important to decide therapeutic strategy for better diagnosis. Recent paper also shows that FFR-guided therapeutic decision had lowered the event probability. Although these two look similar stenosis, there was severe ischemia on the left and mild ischemia on the right. This slide shows the scan protocol of static perfusion and dynamic perfusion, CT perfusion. Dynamic CT perfusion acquires every beat throughout the first pass. This slide shows the diagnostic performance of static and dynamic CTP. static CTP shows a similar performance compared with the dynamic CTP. Here and here. As increasing the summed stress score in CTP, event-free survival decreases, so CTP is useful to predict event-free survival. But the specificity of coronary CTA is not so high. That is the problem. And when CTA and CTP were combined, the specificity can be improved. This slide shows the radiation dose of the static and ischemic CTP in the various centers. Mean radiation dose of static phase CT was 5.9 millisievert, and the dynamic CTP was 9.2 millisievert. These may be decreased. This is our protocol for comprehensive cardiac CT. Stress CTP, dynamic stress CTP can be done only using 3 millisievert when 1 beat skip acquisition protocol is applied with low kV. Total dose of the comprehensive cardiac CT was 7.2 millisievert. This is acceptable for clinical use. This is a case of angina pectoris. Coronary CTA showed the stenosis in proximal LAD. ATP stress CTP shows hyperperfusion in the anteroseptal wall. This is the quantitative measurement, MBF measurement. Also shows the hyperperfusion area in the anteroseptal wall. And there is severe stenosis here in the proximal LAD by CAG. This is in this case, assessment of coronary stenosis is difficult due to severe calcification of LAD, CX, and RCA. Quantitative and qualitative dynamic CTP shows no ischemia. This is a case of sub-end myocardial infarction in the stented inferior wall. Quantitative and qualitative CTP shows hyperperfusion in the inferior wall. This is a sub-end myocardial infarction shown by the MR gadolinium enhancement. And delayed enhancement CT also shows the same finding as the delayed enhancement MR. These are papers which compare CTP and CT-FFR. CTP and CT-FFR showed the similar AUC. We proposed the coronary territory mapping. When we click the stenotic point we can measure the percent area over the whole myocardium. In this case, there is the area at risk of the stenotic D1 area is 30.5%. This is the Voronoi algorithm. We use the Voronoi algorithm to measure volume and percent area. When we click one point here, this point is responsible for the nearest coronary artery. We calculate all the area, all the points, and we can delineate the border of the coronary artery territory. And we propose CT-derived quantitative perfusion ratio, that is a relative flow reserve. This is there is a stenosis here in the proximal LAD showing the reduced myocardial blood flow, that is 1.06 milliliter per gram per minute. Ischemia here, but the proximal area of the bilateral branch is not ischemic, and the myocardial blood flow was 1.72 milliliter per gram per minute. So the QPR is 1.06, the ischemic area divided by the normal area. That makes 0.61, and this is very similar to the real FFR. So QPR should have the similar meaning of the FFR. Actually, the correlation between FFR and QPR is very good. That is better than the correlation between the relative flow reserve derived from the water PET and invasive FFR. So, in summary, a current status of CT perfusion was presented. Performance of ATP stress, static and dynamic CT perfusion was presented. CTP plus CTA can quantify MBF of each branch. New parameters QPR was proposed. That is a parameter of relative flow reserve. Thank you for your attention.
Thank you very much, Professor Mochizuki. That was really a nice overview of the CT perfusion from the early experience of yourself and to the most recent research results. That was really fascinating. Thank you very much. So in the meanwhile, I'd like to move on to the next speaker, which is given by Professor Dr. Cohen Neiman. So he is currently Associate Professor of Medicine, Cardiology and Radiology in Stanford University. And the email address here is wrong. It's for Mochizuki, Professor Mochizuki. So don't send this, use this mail. But he is an immediate past president of SCCT and actually one of the frontiers of cardiac CT in all area. He is going to talk about the plaque quantification with a very intriguing subtitle of Hype or Hope. I'm very interested in his talk. Professor Neiman, please.
Hi, this is Konima from Stanford University. It's my pleasure to present today on plaque quantification, Hype or Hope. In terms of disclosures, I have the following research collaborations, although none of these collaborations are really relevant to the topic of the presentation. So first of all, I think we have to ask the question, why do we want to do plaque imaging? Why are we interested? Because it takes a lot of time. It's cumbersome, and so it makes sense to ask ourselves first, why? Is there a clinical need for it? Is there a way we can improve our risk stratification? Can we follow progression of disease or evaluate the effect of treatment? But ultimately, I think the important thing is, would our imaging of plaque change our decisions about treatment? And would those changes in treatment affect outcome? And those are very difficult questions to answer. In terms of research, quantification of plaque makes more sense. It will help us to understand disease mechanisms, and it can also be a surrogate marker for treatment effect. So imaging of coronary plaque by CT started quite a while ago with calcium imaging in the 1970s. And this is one patient where we evaluated the coronary arteries with CT angiography in 2003, in a time where there was a lot of interest in identifying vulnerable plaque. So this was a very young patient. He was in his late 20s and came in with a ST elevation and suspicion of an anterior wall infarction. Invasive angiography was done, and no significant disease was found. After the cath lab CT scan was done, when patient developed symptoms again, and plaque was found in the LAD, which was quite substantial, as you can see here on the right-hand side, but image quality at that time was not good enough to make many more conclusions. But based on these findings, the patient went back to the cath lab and various different invasive. Plaques start early, but in life, and start small, and then generally progress to either a state of chronic coronary stenosis and angina, or an unstable situation where plaque ruptures causes thrombus and rapid occlusion of a coronary artery with the phenomenon of a myocardial infarction. The ideal of plaque imaging is, of course, to identify patients, and particularly identify plaques that are prone for rupture, identify them early and treat them locally, for instance, with stenting. That was the original idea of the vulnerable plaque, and many invasive techniques have been developed to characterize those lesions. Of course, there has been IVUS, which has been the mainstay of invasive imaging of coronary plaque, but also angioscopy with little cameras directly imaging plaque. OCT, which has a very high resolution but low penetration for evaluation of the surface of the plaque. And then there were IVUS-based mechanical properties that can be evaluated within the coronary artery, such as elastography, palpography. There were other measures like thermography and of course, near-infrared imaging for detection of lipid within the plaque. In terms of plaque characterization in a non-invasive way, this has been investigated with MRI, but for the coronary arteries, I think it's fair to say that this is still quite difficult. For CT, many studies have been performed in the early 2000s to look at differences between the plaques in comparison with IVUS. And it was clear that calcified lesions can be easily distinguished, but the differentiation of hypoechogenic and hyperechogenic plaque on IVUS, which may indicate a difference between fibrous versus lipid-rich plaque, was of course very interesting. Now, several studies have shown in cohorts that there were significant differences between these two plaques, and that was repeated in different studies, but the results were not very consistent. In general, fibrous plaque have attenuation values of around 100, but particularly for the lipid-rich plaques, the numbers varied quite a bit. Studies were not always significantly different, and if you look at the values that were found and compare them across studies, then the lipid-rich values in one study are in exactly the same range as the lipid values in another study. Sometimes they are close to zero, but sometimes they're more around 80 or more. So on an individual basis, the reproducibility still remains quite limited. Another thing that we have to realize is that the values that we measure, the Hounsfield unit values that we then use to differentiate those plaque components, are dependent on the contrast enhancement within the coronary artery, among other things. In an experiment that was done at Rotterdam, my prior institution, a specimen of a coronary artery is filled with different concentrations of contrast medium. And what we saw was that if the attenuation in the lumen increases from 66 to 70 to 502, which is, a typical attenuation in clinical practice, the calcium attenuation didn't change dramatically, but the non-calcified plaque changed from 20, which would be a lipid-rich plaque, to 94, which would be more in the range of fibrous, to 136, which formally would be considered a calcified plaque. So it's important to realize that with different attenuations, the measurements will be different, but there's also other reasons why values will differ, depending on, for instance, on the KV that is used, on the kernels that are used, on the overall quality of the images, as well as the size of the vessels. For culprit plaque imaging, various features that have been demonstrated by IVUS and other invasive techniques have been reproduced with CT as well. For instance, the plaque size, remodeling outward, large non-calcified plaque, low Hounsfield units, and spotty calcifications in different studies were identified as being associated with culprit lesions in patients who came after the event. Whether those characteristics are important for clinical treatment, that's still a topic of debate, even in invasive studies like the PROSPECT study that looked at different IVUS features of coronary artery disease. It became clear that particularly stenosis and plaque quantity are the drivers of adverse events. The virtual histology thin cap fibroatheroma does involve a 3 times higher odds ratio for the development of adverse events. But the question is whether you can really call that a high-risk feature if you consider that the majority of patients, if you look on the right-hand side, the majority of patients, 96%, with this particular plaque will never develop, or at least not within the time of the follow-up of the study, develop an adverse event. So even though the risk is relatively high, the overall risk for the patient on an individual basis is actually still quite small. And the question is whether you can really call that a high-risk plaque and whether you should really base your management on these findings. Now, doing that with a CT scanner is even more difficult. It's even harder to find those thin cap fibroatheromas. We cannot measure the cap, and the only thing we can see is potentially lower attenuations within the plaque. Now, this is one of those examples that you can see over here where there is a plaque, there's outer remodeling. It looks darker on the inside, which may be correlating to lipid-rich tissue, but not necessarily sure. But the question is whether we should not be focusing on single plaques, but maybe on the entire coronary arteries, looking less at an individual plaque characteristics, but more the overall plaque burden and ultimately the vulnerability of the patient rather than the heart. So that's where plaque quantification comes in. The plaque quantification, of course, has been done for a very long time using calcium imaging. You will all know that there is a clear association between the amount of calcium and the amount of atherosclerosis, which is subsequently associated with cardiovascular outcome. CT is very sensitive compared to IVUS for identification of calcifications, has been done with electron beam CT scanners and can be done equally well with today's mechanical CT scanners. There are differences between ethnicity in the amount of calcium that is being built up over time. The calcium itself is not unstable. It does not appear to be very modifiable, but the measure of it in relation to overall risk can be used to move people from an intermediate risk category to a lower risk category or a higher disease risk category with associated management consequences. But of course, calcium is not really modifiable, and non-calcified plaque may be much more interesting for these kind of purposes, and that's why CT angiography comes around. CT is not as sensitive for non-calcified plaque as it is for calcified plaque because the natural difference in contrast is not there. With contrast, we can improve it, but even when you look at these images where the non-calcified plaque emerges in the proximal right coronary artery, even though it was not visible on the non-contrast study, and we can see the differentiation between the lumen and the plaque, it's much harder to see the difference between the plaque and the surrounding tissues. Large plaques we will be able to see, but when plaques become smaller, they also become much harder to see. So early studies, and probably it's a little bit better now, but early studies show that the detection rate of non-calcified plaque was around 75%. Does the information of non-calcified plaque improve our risk prediction? I would say it probably does to some degree. I mean, the number of vessels with disease is associated with outcome, and according to some studies, the amount of plaque is actually more predictive than the number of vessels with significant stenosis. That being said, calcium imaging also has this predictive value, and while there are studies that show prognostic value of CTA plaque imaging, this large study in asymptomatic patients showed that it was very difficult to demonstrate incremental value of CT angiography over calcium imaging for risk stratification. So the question is whether we should really do that for clinical purposes. In terms of research, CT angiography is expanding its role as a surrogate endpoint in trials, and this is one example of a study that we did in patients with bioresorbable scaffolds, where we used the CT scan to follow the luminal dimensions over time, and we were able to show a gradual decrease in luminal dimensions after scaffolding with this bioresorbable scaffold. In terms of plaque, that's a little bit more difficult, but there are impressive examples such as this one, where a plaque gradually over the course of about 7 years increases in size and also in the amount of calcification. CT cannot image with the same resolution as IVUS. IVUS is very high resolution and particularly in plane, and we can do measures of proportional plaque size. On the other hand, CT based plaque imaging has a lot of longitudinal coverage. We're not limited by the area that is interrogated by IVUS, and we can measure the plaque burden throughout the coronary artery tree. The plaque progression has been shown by this study by Dr. Motoyama in 2015, showed that patients with plaque progression have more adverse events. This was done in a large cohort with 2 different CT scans and 4 years follow-up. The total number of events were not great, but it seems like all events, if you look on the right-hand side, seem to occur, except for one maybe, seem to occur in those patients who had positive plaque progression. There have also been studies looking at the effect of therapy, for instance, statin on plaque changes. And this is one retrospective study of patients who had 2 CT scans more than 2 years apart, very large cohort. And what they found was that in those patients who were on statins, the overall amount of plaque was lower at follow-up. It increased in both groups, but it was less in patients on statins, particularly for non-calcified plaque. And actually there was an increase in calcified plaque. There are also prospective studies. This is a study that looked at statin therapy after acute coronary syndrome, high intensity versus standard statin treatment. This was a smaller cohort, and of course, both arms were treated. There was not a treatment-native arm. And in this study, it was very difficult to show differences, but there was an increase in dense calcifications in those patients who were treated with a high-intensity calcification. And in fact, there are many studies that have looked at interventions and used CT for follow-up. And you can find those in this publication in the International Journal of Cardiac Imaging if you're interested. I think a lot of attention was received by the EVAPORATE trial, which was a study on icosapent ethyl, a sub-study of the REDUCE-IT trial, and images were double-blinded, evaluated after randomization between this drug and on a statin, or in addition to a statin. What this study showed was quite impressive, that for their primary endpoint of low attenuation plaque volume, there was a slight decrease in the interventional arm, while there was a continued substantial increase in those patients only on a statin. So the concept of this study, of course, is very impressive, although there has been some criticism on the methodology, and which emphasizes the need for very standardized and well thought out methodology to really measure things in a reproducible way. The challenge with plaque calcification, as I mentioned, is the outside vessel border. And what you can see here is a segmentation that I've done for a patient using different window width and level. And you can see that with the changing of these display settings, I measure completely different plaque sizes. And so in general, the reproducibility of manual plaque segmentation has not been perfect. The accuracy compared to IVUS has been, the correlation has been good, but the variability has been substantial. And depending on the study you look at, there's both over and underestimation. And these studies are usually done in very high quality cases. The fundamental limitations of this are multiple. We don't always realize, but the spatial resolution of a CT scan is maybe 0.5 most optimistically, while we're looking at a 3 millimeter vessel. So things shouldn't be looking like a regular plaque, but should be looking more like this, with a very coarse depiction of the vessel. Of course, things are smoothed out, and it looks like we have better spatial resolution, but in reality, there is a limitation to that. We assume that the coronaries are not moving during the time of acquisition, which is not true. There is continuous motion, which will cause blurring. The contrast resolution of a CT scan is not great, and it's very difficult with CT to differentiate soft tissues. Filtering has an effect on the depiction of the coronary arteries, and then there are things like beam hardening, which also occur adjacent to calcifications and may appear as non-calcified plaque. Overestimation of our ability to see images affected by the ability to distinguish the outer plaque border, but also plaque in small vessels and the differentiation of plaque tissues. When we investigate looks like the presentation got stuck there, but I think we were getting near the end, so that should be fine. So the last part was just about reproducibility and the fact that it depends not just reproducibility between the observers, but there's also reproducibility between scanners, which is not always guaranteed. And you may get different results when an exam is made on a different scanner, and also the fact that the reproducibility between software, which when you evaluate a plaque with the same software, you usually get very reproducible results. You get the same thing twice, and you may think that is therefore very accurate. But then if you would evaluate with different software, you may get a very different answer. So that was the bottom line, and I think that was probably one of the last slides. So I think we can now start the discussion. I think we had some excellent presentations. So thank you all for preparing so well and such a diverse presentation. So in the maybe it was more the back stage discussion. We already had some comments that were very interesting. So maybe we'll pick up on some of those. So just a question for Dr. Park. I'm curious to know, in Korea, what is clinically acceptable right now for CT-FFR? Can you use the standard heart flow application? Can you use the algorithm that you developed yourself?
Oh, actually, unfortunately, in Korea, any of these softwares not available because in Korea every medical reimbursement is pretty good. CTA cost is very low. Even invasive angiogram cost is compared to other countries, it's very low. So I think clinicians don't feel need to use such non-invasive method, but in future we definitely need on-site CT-FFR technology to help our patients by non-invasive method. So usually in clinical research level.
Yeah. I think that's the same in many places. I know in Japan, heart flow is available, in the US as well, but in many other places, I believe it's not. And just to follow up on that, we had a question from Dr. Yang, also from Seoul, who also has a lot of experience with perfusion and FFR, and he asked the question whether, in his experience, MLA is often, comes very close to or correlates very well with FFR. In addition to the plaque features, do you have experience with that?
Oh, sorry. Say again.
So do you think if we could more accurately measure the stenosis, do you think we would still need CT-FFR so much?
Yeah, because I think personally, CT diagnostic accuracy resolution is not good enough. So we definitely need it could be additive help for predicting event with CT scan, but the cost should be lower than I think heart flow FFR CT in Korea, at least. Yeah.
Yeah. So that brings us to. Go ahead.
Sorry. One question to Dr. Park is, you mentioned that high-risk plaque features are kind of predictive for ischemia. What is the background for the predictive value?
So actually, I'm not saying high-risk plaque is almost always related with ischemia. However, high-risk plaque features and plaque quantification information could be additive value for predicting ischemia, especially CT-FFR value range from 0.75 to 0.85 in clinically interested area. It's not enough. So in that area, high-risk plaque features and quantitative plaque information could be helpful to predict ischemia.
I see. So if you find a CT-FFR or border zone, then we should look at the plaque features. Thank you.
Yes.
Yeah, maybe continue with the
Yeah.
We have a little bit of a time delay, but maybe I can, since heart flow is probably quite expensive, perhaps. I mean, in the US, it's hard to beat heart flow. It's very convenient, but given the price of it, maybe that's one of the reasons why perfusion imaging is more popular. I think in Asia, and it's used a lot in Seoul and also in Japan, and I heard in China as well. And so, Dr. Mochizuki, how standard is perfusion imaging in clinical practice? And I'm also curious to know what your standard protocol is. Do you always do the perfusion first, or sometimes also the CT scan first, and then decide whether you do perfusion?
Thank you. Yes, we do CTA first. And for the request of the cardiologist, we do the comprehensive cardiac CT, including CTP and CTA. And we can, but for the clinical use in the most institute, the one phase that is static CTP is good enough and convenient because the dynamic CTP is very time consuming. And we cannot obtain any cost for the CTP. That is a voluntary assessment. So I would like to obtain this similar price like the CTFFR by the heart flow. That may be good, but I think one phase static CTP, I recommend dynamic one phase CTP for the clinical use. It's convenient.
So for those young researchers who want to do something in using CT perfusion, do you recommend dynamic or still you recommend static CT perfusion?
I do recommend both. For the research work, we want to continue the dynamic CTP for the quantification of the myocardial blood flow. And we can calculate relative flow reserve that may add some information for the patient. So I'd like to encourage young researcher to do dynamic CTP as well.
I don't know whether we have time for one more question, but maybe we can keep it short. But one thing I wonder is, like with myocardial blood flow measurements, I mean, we try to do that, and it's very attractive for dynamic perfusion, but it seems to vary between patients, and that's why you also develop QFR. Why do you think there's this variation of perfusion values between patients? Is it technical or clinical?
We are suffering from the lower value of the absolute myocardial blood flow by CT and also the nuclear. PET is a little bit higher absolute value, but the semiconductor detector SPECT and CT is very has a little bit lower absolute blood flow. So we need to enhance the difference. And MR is also, but I know Kakuya is the expert to enhance the myocardial blood flow by MR.
Thank you very much for the compliment. Cohen, there's a couple of questions to you. Actually, one is from the audience that for a plaque characterization, can we use a low KVP? And there's another question that what is the optimal vessel enhancement for plaque visualization?
Yeah, it's a good question. I think with higher values of attenuation in the lumen, we see more effects, side effects of the blooming and increase of the plaque values that we measure. So limiting that is actually better for plaque imaging, even though it's less optimal for stenosis detection. So I think what was recommended by some is around 300 Hounsfield units for the lumen is actually for the plaque imaging quite good, and but maybe not always optimal for detection of coronary stenosis in small vessels. But I think in addition to that, at least as important is the control of like motion artifacts, because if you have like motion-free coronary images, that makes a huge difference for plaque assessment. So I think that will be one recommendation. And I think we're currently writing a guideline for plaque imaging within the SCT and try to give some guidelines how to optimize it, and particularly for research when we want to study and repeat the evaluation, how we can do that as accurate as possible and as reproducible as possible. So we are very sensitive for identifying differences.
Thank you very much. So we are almost running out of time. Okay, Professor Niemann, can you say something? A few words?
Well, it was a pleasure to be here. I mean, these were great presentations by experts in the field and by friends who have worked with for so many years. And so it's a pleasure to be here. And that also makes it such a shame that we are not physically in the same place. But still, I enjoyed it very much, and I hope we can continue the great collaboration between Asci and the SCCT in the future. And we get to meet up either next summer in Las Vegas or at the next Asci meeting.
Yes.
Thank you.
Yeah, Asci is also looking forward to a continuous collaboration and updates from SCCT. Thank you very much for joining us today. And everybody online, thank you very much for joining the session. I'd like to close this session. Thank you very much Dr. Park, Dr. Mochizuki. Thank you very much.
Thank you very much.
Thank you. Thank you very much.
with immediate access to potential users around the world. Bayer is illuminating the path forward, generating results from a world full of potential. We're excited for the journey ahead. Let's take the next step together. We want to meet you. Schedule a meeting to share what you're developing.
My journey continues, and I know I'm not alone. Because together we can make a difference every day.